Hello, and welcome to this AJMC program titled Considering Cost Effectiveness in Cardiovascular Risk Reduction. I'm Dr. Deepak Bhatt from Brigham and Women's Hospital and Harvard Medical School. Joining me today in this virtual discussion are my colleagues, Dr. Adam Bress from the University of Utah School of Medicine, Dr. Matthew Budoff from the David Geffen School of Medicine at UCLA, Dr. Eric Cannon from Select Health, and Dr. Anne-Marie Navarre from Duke Clinical Research Institute. Today, our panel of experts will review opportunities for reducing residual cardiovascular risk in patients at high risk for cardiovascular events. They will also focus on the role of cost effectiveness in therapy evaluation. So let's go ahead and begin. So first, let's talk a little bit about determining cardiovascular risk and talk a little bit about the burden of cardiovascular disease and risk stratifying patients with cardiovascular disease, the role of dyslipidemia in particular, particularly the role of LDL cholesterol and triglycerides on cardiovascular risk. And of course, the patient perspective is the most important. But let's start off here with a discussion from the payer perspective. Cardiovascular diseases, of course, are one of the most, if not the most costly healthcare expense, I'd say, among chronic diseases in the US, but even to a greater extent worldwide. What exactly is the reason for that? What's driving these costs? And what can we do to reduce not just cardiovascular disease, but the associated health economic consequences? And to start us off, let me turn to Dr. Cannon. What are your thoughts on that?
Yeah, no, I think if we were to look at cardiovascular disease, if we were to look at the costs associated with that, we know that is one of the most significant drivers of cost that we face as a health plan. And I think if we look at the social responsibility that I think we believe we have to the community, it becomes an imperative that we take care of that. And so knowing that hospitalizations associated with cardiovascular disease are going to drive significant costs, knowing that part of that cost is driven by readmissions. We are working very diligently to not only focus on the existing patients that we know about, and I think managing risk factors for patients you know about is one thing, but then really taking that more globally out into the community and how do we reduce the overall risk of the community. And so focusing on things such as obesity, diabetes, you mentioned LDL cholesterol levels, triglycerides, and really how do we appropriately screen patients, find patients, implement effective lifestyle changes, knowing that this is the single biggest driver of our costs. It becomes a very meaningful intervention. I think more than that, if we look at what drives economic burden for our patients, and there's been some research published recently that really looked at the economic burden on patients, and knowing that the more we reduce those risk factors, the better the health of our patients, but moreover, the better the health and economics of our community.
Yeah, I really liked how you brought in the social responsibility aspect of it. I think you're right. Third-party payers do need to think about that aspect of social responsibility. It's the right thing to do on a moral level. And it's also, I think, good for business. That is, if one is concerned about healthcare costs, investing in prevention can do, I believe, a lot to prevent downstream healthcare costs. And of course, just from a patient's perspective, is the right thing to do. I'm also glad that you mentioned community health, because a lot of these issues can be addressed, I think, quite optimally through that approach.